And I just want to encourage you, another housekeeping, if you don't have a name tag yet, please visit the registration table in the lunch break. Even if you've registered online, they'll give you a name tag, which is just nice to be able to chat. And also, if you haven't registered, you can register there. And I did want to share just briefly the money that's raised today. Some of that will be going towards water filters, Filter Water for Life, I believe. And that these are have been used in Papua New Guinea, and it's reduced morbidity significantly in remote areas that get water from the rivers. And it's literally, they just provide the bucket and this water filter gets attached, and it lasts for 10 years, which is amazing. And it's been a great success in helping people in these remote provinces. So thank you. I'd like to say thank you for registering and any donations that you give, and also as the day goes on. I'd like to introduce our next speaker, Dr. Rowe, or Libby, as she's called. Just a brief sharing, you can read about her in the bio, but Libby started helping people with eating disorders over 35 years ago. Before there was much awareness about it or different organisations helping people, and she had to learn as she went. So she has a lot of great knowledge. And a fun fact about Libby is she loves walking with her husband and dogs on the beach daily. And she makes the most amazing rocky road. So if you want a great recipe, you can ask her afterwards. So please welcome up Libby. You can just adjust it.
Okay. Oh, wrong way. Oh.
Keep going. I'll make you go back.
Okay, thank you. Well, welcome everybody, and thank you so much for supporting this event today. Eating disorders is quite a big topic, so I thought I'd start by sharing the two most important things that I hope you'll take away from this today. The first is an understanding of the myths and misconceptions that surround eating disorders that abound in our community. These contribute to stigma, and stigma affects patient presentation, care and outcomes. I'd like to share some of these by way of a written piece by a patient with a lived experience of anorexia nervosa. I'll be calling her B. The second thing that I hope you'll take away from today is a list of around 50 plus symptoms and signs of eating disorders, so that we can all help identify a patient who might be suffering and need help. Patients with eating disorders can be quite secretive and often due to stigma and shame, so the people close to them may not be aware of some of the behaviours that they're exhibiting. And for example, you could be a teacher at a school and you could see a child arriving at school every day throwing their lunch in the rubbish bin. Their parents may not become aware of their weight loss until several months later. You could be a gym instructor at the local gym and see that a particular gym member is doing 10 to 14 sessions a day, cardio, cycling, boxing, and you may be present as an instructor when that person almost faints. You could be a mum, and every time your child's best friend comes over, you notice that the family toilet smells of vomit. So they're all scenarios where somebody other than the family member might notice a concerning behaviour and be able to intervene. Those symptoms and signs will come up in the slide presentation under warning signs. But I'd like to start by reading B's story. I don't remember ever wanting to be a princess, a ballet dancer, or a pirate. My idea of a fairy tale was to fall in love, marry the man of my dreams, and have lots of babies. Life was easy as a child, filled with dress-ups and painting and laughing. There was no reason to believe that fairy tales don't come true. But then I got sick and life got harder. I got hit with a hard illness. Not that any illnesses are easy. Unfortunately though, my illness comes with many stereotypical beliefs and negative connotations. Most people believe that there is an easy way of fixing it, but they're wrong. There is no easy way. And I suffered in silence for a long time, believing no one would understand. I don't remember the beginning, if there actually was one. Maybe it started when I was branded a bush pig during the 2.5 years I was bullied on the cusp of adolescence. Maybe it was the moment I went to boarding school and left my safety net, my mum and dad. Or maybe it was always with me, bubbling below the surface, waiting for the right moment to start infiltrating my mind and becoming a part of me, so I wouldn't notice the difference until it was too late. I can still vividly remember my first hospital admission, being told that every move would be monitored and that I was to be on strict bed rest. The feeling that night of lying in a strange bed with no idea what was in store was one of the loneliest and scariest nights of my life, and there were unfortunately many more to follow. For many years, hospital became a state of mixed emotions. I was powerless, unable to do anything that at the time was of comfort to me. Everything was deemed to be the anorexia nervosa's voice. This was something I couldn't understand. Anorexia nervosa's voice wasn't a separate entity. This was me. These were my thoughts. Why were people telling me to fight the voice and separate it, name it? There was no voice in my head. These were my feelings. How was I to distinguish the difference between my thoughts and anorexia's thoughts when it just felt like me? Despite all this, hospital was also a comfort for me. It took me back to being a child again, having someone care for me, make the decisions for me. I didn't have to decide when to get out of bed, when to eat, or what to eat. The decisions were made for me, and this brought so much relief and comfort. When I was discharged, I felt alone again with my illness, with no one to help me with the constant struggle and the never-ending feeling of disgust in myself. The only way I could seek solace from my mind was to eat as little as possible and to run, despite logically knowing that it would just put the cycle into motion again. Despite wanting to get better, part of me was so scared of it as well. I wondered what would go on in my mind if everything that was deemed anorexia's thoughts were to leave. It is a part of me, and I don't feel that I have ever thought any differently. But this is the crippling nature of an eating disorder. No one wakes up in the morning and has anorexia. It happens slowly and cunningly until the point of no return, until you start to believe that they are your thoughts and feelings. Outsiders believe that just eating will fix the illness. You probably will have heard at least once, maybe twice, that eating disorders are not actually about the food. The food just becomes a way of attempting to manage and control the intense emotions and thoughts that go on inside. And at the time, it seems like the only way. But with restriction comes more restriction. There is never an end point, a point where the mind says, yep, all good now, you're okay. It's all about eating less next time or running further and harder next time. It took me a long time and a lot of hard work by my doctors to be able to express my emotions verbally, to be able to find different ways of dealing with my feelings, to learn to trust myself and believe that I'm okay. It meant letting go of things that had been so comfortable but so damaging for so long. I've had to learn to reach out to my friends and family when I need it, not to seek help from my crippling disease. It's still so easy to fall back into the familiarity of the eating disorder when things seem unbearable, to listen to those feelings and to start to minimise meals or run a bit further. But I'm now aware of the things and people that would be put on the back burner if the illness was to fully consume my life again. I would lose the spontaneity that I've taken so long to learn. I would lose my work, my friends, and my responsibilities. But most importantly, I would lose the respect and love that I am now slowly building for myself. This has happened in baby steps with many, many setbacks, but by trusting my doctors, my family, and my friends, I'm starting to realise that I am okay. No, I'm not living out my fairy tale, but I'm doing the best I can in this crazy thing called life and beginning to quite enjoy it. So I think the myth that B most ardently addresses is the issue surrounding eating disorders and food. And as she states, eating disorders are not just about the food. Eating disorders are actually psychiatric illnesses, and the food is the expression for that psychiatric distress. So the food and eating are symptoms and signs of that illness and largely under the control of that eating disorder. So an individual may have very little control over those behaviours without treatment. So when you hear the quip, as we probably all have, that the patient with bulimia nervosa needs to just stop vomiting, or the patient with anorexia nervosa simply needs to eat more, you'll understand that that shows a significant lack of understanding of the psychiatric nature of these conditions. They may have very little control over that. The issue of control and choice is probably a great segue to the next point, which is that patients do not choose to have an eating disorder. You can't blame them for having an eating disorder. It's an illness like any other. It develops in the setting of underlying risk factors, environmental stimuli, and a precipitant, and the illness evolves. And as Bea said, sometimes quite cunningly and insidiously. I mean, one could facetiously and with a bit of poetic license liken telling someone with anorexia nervosa to eat more to telling someone with leukemia to go and sort their white cell count out, to stop producing so many. We know they can't do that without treatment. So the next myth is a view held by some in the community, which is that patients with eating disorders are just vain and full of self-love and completely absorbed by their bodies and what they look like. And if they weren't so vain and superficial, they wouldn't have developed an eating disorder. Certainly, a number of patients with particular eating disorders do have body image dissatisfaction. But vanity, self-love, absolutely not. These patients have a self-loathing that is as vicious and relentless and uncompromising as you can possibly imagine. And as Bea said, often they have disgust for themselves. And often the voice of the eating disorder means they're never good enough. There's never an end point. They just have to eat less and run further the next day. If these patients did have some vanity and some self-love, fueling and nurturing their self-esteem, they would be dramatically less likely to ever develop an eating disorder. The final myth, I think, perhaps pertains more to people who might have been involved in the management of patients with eating disorder, and that is that these patients are difficult, uncooperative, arrogant, refuse treatment, and objectionable. There's no doubt that some eating disorder patients do resist treatment, but it's important to understand the reasons why, and the main reason is fear. As Bea said, the first night in hospital for her was one of the scariest nights of her life, and there were many more to follow. As she also said, one of the other scary things was contemplating giving up or getting rid of the eating disorder when she thought it was her, when she believed that was who she was. I think this also highlights how important it is for all of us to treat patients with eating disorders as people and not as eating disorders. Many of them just think they are an eating disorder anyway, and really part of their recovery is to reclaim themselves, to re-establish who they are as a person without the eating disorder. All right, I'd like to move on to the slides now. So what is an eating disorder? Complex, potentially life-threatening psychiatric condition characterised by significant disturbances in eating behaviour that result in serious medical, psychiatric and psychosocial consequences. It is not a disorder of weight management. When we think of eating disorders, we tend to think of the typical white, emaciated young woman with anorexia nervosa, but we need to think more like this. Patients with eating disorders come in all shapes and sizes, and you certainly can't make a diagnosis or assess medical risk based on external bodily habitus alone. Eating disorders are classified by DSM-5, which is the Diagnostic and Statistical Manual. We're up to the 5th revision, which was released in 2013. We'll touch on the first 5 of these. Anorexia nervosa involves a restriction of energy intake resulting in significantly low body weight or a less than minimally expected weight. DSM-5 does not put a quantity or a value on this, although generally, commonly would correspond to a BMI in adults of less than 18.5 or in children less than the 3rd percentile for age. But the reason why these figures are not part of the criteria is that if you had a 14-year-old girl who was sitting on the 60th percentile of BMI for age for most of her life, as children tend to, and she dropped to the 10th over a number of months, and she met the other eligibility criteria, you would definitely make a diagnosis of anorexia nervosa. You would not wait until her BMI percentile had dropped to less than the third, because she probably wouldn't still be alive then. The second criteria is intense fear of weight gain or fatness, or, in small print, behaviour that interferes with weight gain despite the low weight. A patient may not admit to you that they are frightened of gaining weight due to shame or stigma, but if their behaviour interferes with the weight gain regardless, then they meet that criteria. Disturbance in body image is the third criteria, and again, a patient may not concede that. So the other riders in small print are self-evaluation unduly influenced by body weight or shape, or persistent lack of recognition of the seriousness of the low weight. It can be restricting or binge purge in type, and the severity is rated according to the actual BMI in adults. Bulimia nervosa involves recurrent binge eating occurring at least 1 or more times per week for 3 months, with inappropriate compensatory weight control behaviours, such as vomiting, laxatives, diet pills, diuretics, and excessive exercise. Not all exercise is good. I think it's important to sort of define what binge eating is, because it is used fairly colloquially in our society these days, but it's eating in a discrete amount of in a discrete period, an amount of food that is definitely larger than most would eat in a similar situation and time period. So if you've got a Christmas day and you start with your salmon blini and champagne cocktail at 11:30, and you work through all your courses, and you're having your cheese platter and dessert wine at 5:30, and you may have consumed maybe 3 or 4 times what you would normally eat in a day, that is not a binge. That is a justifiable cultural feast, if you like. Binging does tend to occur when the individual's on their own and is associated with shame and guilt. Binge eating disorder, that's subjective binge eating at least 1 or more times per week, but without the compensatory behaviours. So these patients will often end up gaining weight. Binge eating disorder was only introduced onto DSM for DSM-5 in 2013. Prior to that, probably many patients with binge eating disorder would have been diagnosed as obesity, treated as obesity, and unsuccessfully, because obesity is not a psychiatric condition. OSFED, this is really a collection of all of the sub-threshold eating disorders. One of note in particular is atypical anorexia nervosa, or normal weight anorexia nervosa, which is where the individual has all of the same behaviours and thoughts as anorexia nervosa, but they're not actually underweight. Unfortunately, though, a lot of the research has shown that these patients are not the weight that they need to be for their body, and they are essentially malnourished, and they suffer a lot of the same consequences as the underweight anorexic patient. ARFID also came onto the DSM-5 in 2013. Prior to that, it was thought just to be a disorder of toddlers. It also, like anorexia nervosa, involves a restriction of intake, but there's no body image disturbance. There's a significant overlap between ARFID and autism spectrum disorder. So these patients will choose their foods or limit their foods, sometimes based on sensory aspects of the food, and that can be totally individual. So, for example, somebody with ARFID might say they don't want to eat a Tim Tam, but not because it's got high in calories, like someone with anorexia would say, but because it's brown, like the colour of dirt. And they may not want to eat yogurt because it's slimy, or an apple because it squirts out juice when you eat it. So there are a whole lot of very idiosyncratic food qualities that make preparing their meal plan and recovery quite difficult. How common and who? The epidemiology surrounding eating disorders is always difficult because many patients are undiagnosed, or many patients are diagnosed with the consequences of their eating disorder, but not the eating disorder itself. This was from the research done by Deloitte in 2023, called Paying the Price, that was particularly looking also at the financial cost of eating disorders. In 2023, okay, thank you. In 2023, thanks, they showed that 1.1 million Australians were living with an eating disorder, but other studies have suggested it's at least 2 to 3 times that. Also of relevance, women are 2 times more likely than men to experience an eating disorder, and people aged 15 to 19 are 2.7 times more likely than the average Australian to experience an eating disorder. Now, the figure that really should shock us all is the economic cost, $66.9 billion. If you look at breast cancer, $4.7 billion. Cardiovascular disease, $14.8 billion. Dementia, $18 billion. The only thing that really sort of out-trumps this is depression, which is $151 billion. So what's the impact? Well, certainly both psychiatric and medical instability. And the medical instability can be due to malnutrition, electrolyte disturbance and dehydration, and the psychiatric risk, malnutrition, coexisting conditions, because many patients do have, many people do have anxiety and depression regardless, and also all the normal psychosocial stresses that occur in all of our lives. Anorexia nervosa has the highest mortality rate of any psychiatric illness and has a high suicide rate. There are significant comorbid illnesses, both psychiatric and physical, including osteopenia, osteoporosis, gastrointestinal illnesses, infertility, diabetes, and obesity. So what are the causal factors? Now, these are really important because these help us determine what prevention might be like in our society, because ultimately, like any medical condition, prevention is always going to be better than cure. Individual factors include gender. So, as we know, females twice as more likely than males to develop an eating disorder. Body weight, body dissatisfaction, age, puberty. We've seen the age group of 15 to 19 having an increased incidence, but also occurs at other hormonal times, postpartum and menopausal. Also specific personality traits and a history of sexual or physical abuse. Genetic factors. We've known for a long time that there's an increased risk of anorexia nervosa in first-degree relatives. If your mother had anorexia nervosa, you are 10 times more likely to develop anorexia nervosa than your peers. There is a higher concordance in monozygotic, so twins that have exactly the same genetic material compared to zygotic twins. We also know that there are 8 different genes now associated with anorexia nervosa in different combinations, and ongoing research is occurring with that. Parental attitudes is another very common precipitant, with parents who have high expectations of individuals in terms of their performance. Now, whether that be academic performance, sporting, music, whatever, and also their appearance and weight. Family dysfunction, where there's enmeshed families, or intolerance of autonomy. Sometimes young people feel the only thing they can control is what they put in their mouth. And also families where there's impaired conflict resolution. And if that impaired conflict resolution was not evident before someone in the family got an eating disorder, it will certainly become very apparent once that occurs. Availability of highly palatable food. People do not binge on grilled fish and salad. They binge on energy-dense foodstuffs. So if you don't have them in your pantry or fridge or freezer and you can't get to a supermarket or an IGA, it's hard for you to binge. Cultural factors. Preoccupation with thinness is still unbelievably prominent in our society, in spite of many moves to try and prevent this. And the influence of social media has just added to that. changing and conflicting roles for women and men, and attitudes of peers. So if you're a school student and you turn up at school with your salad sandwich and a homemade muffin, and your friends are sitting there at lunchtime saying, oh my God, you're eating carbohydrate. How come you're eating carbohydrate? You know, it's very hard for a 14-year-old without nutritional knowledge to then go against all their peers and think, oh, I shouldn't be eating that. How do eating disorders present in primary care? Well, the classical presentation is a parent bringing a child in concerned about their weight or their eating habits, or a child who's not growing according to expected. I once had a mum who brought her son in. He was about to go into year 7, and she was very concerned that he didn't fit in to the same pants as his older brother did when he went to year 7. They were way too big. Now, as it turned out, yes, he certainly was growth stunted, and he was dramatically underweight, and he had anorexia nervosa, but she hadn't noticed the dietary aspect or the weight. She just noticed that he didn't fit into those pants. Request for assistance with weight control, because that suggests body image dissatisfaction. Ongoing GP visits for other problems, you know, stress, menstrual problems, lack of energy, fainting. And then there are those patients who slip through the system completely and present with chronic consequences of their eating disorder. So osteoporosis, infertility, gastrointestinal problems, and those with financial and housing insecurity because they've been unable to hold down a job due to their psychiatric illness. Warning signs. Now, these are all on the slides that you'll get, but physical warning signs: sudden weight loss or gain, or fluctuation, dehydration, dry hair or skin, sensitivity to the cold, feeling faint, cold or tired, injuries relating to over-exercise, self-harm, palpitations, dental problems from vomiting, cessation of menstruation or irregular menstruation. Knuckle calluses, they can develop from vomiting when people put their fingers into their throat, and as they pull their hand out, they scrape their knuckles on their teeth. Behavioural warning signs, I won't go through all of these, but they will all be available in your slides that you have. Restricted, rigid diet, fussy eaters, throws away food, social isolation. I mean, social activity often involves food. So people will sometimes therefore avoid having to be in a social situation so they don't have to eat. Frequent weighing, constantly talking about food and diets, wearing baggy clothing to either hide their underweight state or their overweight state. Calorie counting, excessive use of the toilet, excessive exercise, the compensatory behaviours like use of diet pills, supplements and laxatives, and making excuses not to eat. Psychological warning signs, preoccupation with foods, body image problems, so negative body image, distorted body image, negative comparisons with others, which has been dramatically aggravated by Instagram and other social media platforms. Feelings of lack of control, social withdrawal, depression, anxiety, hopelessness, suicide. Perfectionism is another big one. Guilt and heightened anxiety around meal times. So the diagnosis and assessment of EDs, of eating disorders, is just the same as any other medical problem. The doctor does a history, examination, investigation, and then initiates management. But the patient may be deceptively well, and they may not give you a thorough history. You may need to get history from other family members. So the history, we're looking at, you know, things from the physical warning signs, from things from the behavioural warning signs, with a particular focus on eating and exercise. The examination, we would also always want to do the height and the weight, the body mass index and the body mass index percentile for children, and lying and standing blood pressure and pulse, because this is an important indicator of cardiovascular instability, which is a very important factor. The investigations we do, ECG, bloods and radiology. These are to look for the impact of the eating disorder on the individual, but also to exclude other physical causes. We don't want to miss some other physical cause. And it also is helpful in terms of if we're wanting to initiate medication. Some of these things are very important to establish that they're in the normal range. The diagnosis, there are differential diagnoses that we would always consider, but can usually be readily excluded by history, examination and investigation. Always need to consider the comorbid presentations as well. I remember as a medical student seeing a patient who was 35 kilos in weight, and initially we thought, oh, yeah, she's got an eating disorder, but no, she had OCD, and she spent 20 hours a day cleaning and didn't have time to eat. So the principles of management. So firstly, securing medical and psychiatric safety. If the person is unstable, they require hospital admission, and there are certain parameters that determine that, which I'll show you on the slides, but I'm not going to go through in detail. We need to engage the patient and family in the treatment process. These disorders, as I said, are heavily stigmatised, so there can be often a resistance to the diagnosis by the patient or their family, or both. We would establish a treatment team, and not every patient needs 5 people in their treatment team. It's really quite an individual assessment depending on the diagnosis and the severity of the condition. The goal is also weight restoration or stabilisation, and the assistance of a dietitian can be very helpful with this. We want to promote normal physiology, so gastrointestinal function, temperature control, resumption of menstruation, optimisation of dental health. We also want to achieve psychological and psychiatric well-being, and there is often a psychological therapy that will be ideal for that particular patient, but there are a number of different psychological therapies, so it's a matter of determining what's right for that particular patient. Pharmacotherapy, if required, and different medications are indicated for different eating disorders. And ultimately, the goal is for the patient to return to normal eating, functioning and lifestyle. These are the guidelines for the treatment of eating disorders that determine admission for a psychiatric admission and a medical admission for adults and for children. Psychological therapy, the gold standard for anorexia nervosa is FBT, or family-based therapy, which is where the parents supervise and sort of control all of the dietary intake of the individual. And then cognitive behavioural therapy for eating disorders for adults with bulimia nervosa and binge eating disorder, whole range of other psychological therapies. The next few slides deal with the treatment options for patients. I'm going to zip through these because I want to get to the case study, but essentially it depends on the age of the patient, what their diagnosis is and where they're located, and whether the illness is mild, moderate or severe. Mild and moderate conditions can be managed in the community. Severe generally need admission or a day program. So as I said, just going to zip through these, but they're in your slides. And these are some of the private sector or fee-for-service eating disorder programs, resources reference. Okay, let's move on to Maddie. So Maddie is now a 17-year-old. She's an elite diver. She's about to do a handstand dive from the 10-metre platform at MSAC. She's on a full VIS scholarship, and she wants to go to the Olympics. So she's 17, she's in year 12, she's a high achiever, she wants to do medicine, she lives at home with both parents and a younger brother, and her parents are both high achievers too. Her dad is a neurosurgeon and her mum is a county court judge. She's got an implant on in situ for menstrual control so that doesn't interfere with her training or competition schedule. Not on any other medications, no known allergies, non-smoker, non-drinker, no use of illicit drugs. She's fully vaccinated. She's got a family history of an uncle with celiac disease, and her mother has irritable bowel syndrome, which is definitely aggravated by watching her dive off the 10-metre platform. She decides that she wanted to become vegetarian 4 months ago. She's a bit of an animal activist, loves animals, and has made this decision on that basis. Has a 3-month history of gastrointestinal symptoms, which include bloating, fullness, nausea, and has now gone on to constipation. She also now has a 2-month history of significant fatigue, and this is the thing that's bothering her most because it's affecting the things that she needs to do to achieve her goals. So it started interfering with her ability to get out of bed in the morning to get to MSAC by 6 a.m. And it's affected how she feels when she gets home from MSAC, from her afternoon training, which is 4 till 7 every day. She just used to do 3 hours study, but now she's finding she needs to go straight to bed. Her mother has noticed weight loss and some behavioural changes. So at this point, what are the possible diagnoses? Well, we'd certainly have to think of an eating disorder such as anorexia nervosa, but iron deficiency anemia because she's become vegetarian, celiac disease, she's got a positive family history, gastroesophageal reflux disease, she's always going head first into water, irritable bowel syndrome like her mum, and anxiety and depression. She's under a lot of pressure. We'd also consider the differential diagnoses and would be able to hopefully exclude all of them by way of further history and examination and investigation. The more detailed history reveals that she doesn't have any other gastrointestinal symptoms. She has lost about 5 kilos in weight, but she's happy with that. She actually wanted to lose weight. She thought that she looked a little bit muscular in her formal dress, which is coming up, so she sort of wanted to lose weight, but no other compensatory behaviours. Gynecologically, she had spotting initially on Implanon, but now completely amenorrheic, and she's not sexually active. From a psych point of view, she's certainly noticed increased anxiety. Her mood and sleep is normal. She denies suicidality. Her mother describes that she's now picking at her food. She's very fussy about what she eats. She eats different meals to the family, even though her mum is accommodating her vegetarian choice. And she's wearing thermals in spring in Melbourne. So the physical examination, her temperature and rest rate are normal. The blood pressure drops from 90 on 55 to 80 on 52 on standing, and pulse 52 to 68. Her anthropometry shows a height of 165 centimetres, which is 50th percentile, weight of 49 kilos, which is the 25th percentile. It was 54 kilos, which would be the 35th percentile. And her BMI is 18, which is the 10th percentile. Previously, her BMI was 19.8, which was about the 30th percentile. The respiratory, cardiovascular, abdominal examination, all normal. The periphery was cool, but not cyanosed, and there was no other findings, in particular, no other lymph nodes or bruising or skin changes. Investigations. All the blood tests were normal apart from a slightly low ferritin or body iron store, and her ECG showed a sinus bradycardia right on 50 beats per minute. So final diagnoses, anorexia nervosa restricting type and iron deficiency. Is she medically stable? Well, this involves knowing all of those criteria for the Royal Australian New Zealand College of Psychiatrists, but she is medically stable. Her heart rate is right on 50 beats per minute. I guess one of the challenges with someone like Maddie is she's an elite athlete, so her heart rate, resting heart rate, would have been lower to start with anyway. Sorry. But she doesn't meet any of the other criteria. So the principles of management are what we went through before. And I guess the dilemma with her particular situation is that she's an elite athlete and she loves her diving, but she's going to have a break from her diving. Being on a full VIS scholarship, would she choose to get the VIS psychologist, the VIS dietitian, or would she want to do that privately? Her iron deficiency would require treatment, either by oral medication, but that takes a bit longer and has gastrointestinal side effects, and she's already got gastrointestinal side effects, or maybe intravenous supplementation. And we'd want to consider whether her anxiety needed treatment, it may or may not, and ultimately she's wanting to return to her normal functioning and lifestyle, which for her means getting back into the water. Thank you.
So I just want to say a huge thank you to Libby for your insightful presentation. That was just such a great way of compassionately deconstructing so many of the myths and misinformation that stigmatizes eating disorders. So thank you so much for that. We'll just give you that small gift. So just a reminder, if any of the talks bring up any feelings or questions today, we have professionals at the resource stand outside, so you can have a conversation or a debrief there. We now have 30-minute lunch break coming up, so please note we have special tables for dietary requirements, including gluten-free and vegetarian. So if you're not those things, also please try and not go for that straight away, so the people who need that have that. We also have free instant coffee and tea, but if you want a fancy barista coffee, we have that available outside for a donation to Hope, which also helps raise funds for the, like the water filters that Vicky was talking about earlier. And we also have lots of stands you can learn more information about Hope and the other resources of our sponsors today. So yes, go grab some food, freshen up, and we'll be back here promptly at 1:45. Thank you.